All right. Let's let you take a minute, catch your breath. Let's put some stuff out to the crowd here. Tasty cakes. The crimpets are out. Who can catch? Oh, what a grab. Oh, I see hands up. We like that look. Oh! Oh, coming in hot. Oh. Let's do a little more. You guys look hungry. We like to keep you well fed here. All right, these are the peanut butter candy cakes. The hands go up. Oh, by the way, there's nasal aid sinus rinses up here. As I say every year, they think I'm a doctor. They can barely put on a conference. There you go. Oh! Doesn't always work out. We'll get you. We'll get you. All right. We got some stuff for later. A little slow here today. All right. So we've got 2 talks before we take lunch break at 1. We've got another Apple Watch giveaway at 12, and we will move along. This is can you put the last email link up? Charlie? I have to go all the way back. All right. It was up for a while. No problem. See my team at the table over there? And they'll give you can skate in with them. And if that happens and you don't get to click it, see my team there. They have everything on paper that you can use. All right, next up. Get up here. She's got her spring outfit on. You know what? Let's give away something else. Let's give away free registration to the conference for next year. Pick a good one. Yeah. Tina Dion. Tina Dion is another Zoom attendee. So we'll take that out. Tina gets free registration to next year's meeting. And now I'll introduce you. This talk, CO2 monitoring of protocols and advanced care sleep studies. Lisa deguzman is the sleep lab and PFT lab manager at Nemours Children's Hospital in Orlando. She speaks at national and global conferences and webinars discussing CO2 monitoring in sleep labs. This talk is about how monitoring is used along with therapist-driven protocols to provide diagnostic and advanced care therapeutic sleep studies. You can put that on. Don't put it on the lanyard because it'll flop around. If you put it up here, it's better. That way you don't get all that noise. Good. Perfect. Okay. You going to stay at the podium? Let me see if I can get that to work for you. You start with this, and then I'll see if I can get that to work. All right, please welcome Lisa.
name is Lisa deguzman, and I am very happy to be here from Florida. I arrived last weekend in Pennsylvania, and I will say Pennsylvania weather is a little confusing to me. I arrived and it was sunny, it rained, and I'm used to that. It went back to sunny, I put a t-shirt and shorts on to go running. You're probably thinking she doesn't look like a runner, but my interest is the zombie apocalypse. I do 4 miles at least 3 times a week so I can outrun most. But anyway, I went out to run, and within 30 minutes it was snowing on me. 30 minutes after that, by the time I got back, it was sunshine again. So I went to do some yard work for the friends that I was staying with, and it snowed on me again. Showered, and by the time we left for dinner, it was in the 20s and 20-mile-an-hour winds. So I got all 4 seasons in one day. So Pennsylvania, I am enjoying the cold weather. We're sweating in Florida already. I do promise any meeting that I go to that mentions policy and protocol, this is what my brain does. This will be not the most boring talk that you've seen on policy and protocol, and I'm going to work some CO2 monitoring into this talk in the sleep lab specifically. Oh, there we go. That's me. As Michael mentioned, I am the sleep lab and PFT manager at Nemours Children's Hospital in Orlando. I spent 15 years in the NICU, the neonatal intensive care, and this is going into my 20th year in pediatric sleep. So you are going to see the perspective from a pediatric sleep lab. That's where I'm from. And for full disclosure, I do have a consulting contract with Centec, who's not at this conference, but we do have some transcutaneous technology here at this conference, so that's exciting. And we'll be talking about both end-tidal and transcutaneous. Oh, wrong way. The objectives today, we're going to review how the guidelines and standards differ between adult and pediatric studies, because that does play into how we use CO2 monitoring in the protocols that we've developed in our sleep lab. We're going to discuss the role that it plays and, again, how we fit it into these policies and protocols to have therapist-driven and technologist-driven protocols. We're going to look at some case studies at the end and show how CO2 monitoring was used and how we use it to diagnose and treat live patients with some autonomy that not all sleep labs, I think, get to enjoy, but with the CO2 monitoring and the policies and protocols that we've developed, it's a great thing. It helps patients, and we're going to talk, I just wanted to show you two. We are a pediatric lab, and 9 beds. We're open 7 nights a week. We employ 10 to 11 full-time technologists at night. We use 2 full-time day scorers. We have a clinical educator, 1 manager. We have dedicated off-team and schedulers. And then our pulmonary physician, we had 2 of our pulmonary physicians are our sleep medicine doctors. So again, just a kind of a glimpse into where I'm coming from and how we've developed over the years. When I first started in 2005, we did about 400 studies a year. And by 2023, this last year, we came in at 2,200 studies. We are booked, when I made this slide, it was September, and I'm sure it's October now. So we are booked really far out into the future. Popular, unpopular. Today, most of our team does consist of respiratory therapists. We have a mix, and right now it's about a 75% mix of respiratory, dually credentialed sleep technologists, and then 25% sleep technologists. You couldn't pry the non-respiratory sleep technologists out of my hands. They're amazing. The entire team is amazing, but because of some of the complex patients that we see, we are a hospital-based pediatric lab. And some of the titrations that we do employ respiratory therapists that are dually credentialed in sleep as well. We're going to look at some of the benefits of having these dually credentialed RRT, RPSGTs, and one of them is ventilator titrations. We are hospital-based, we're on the outpatient side of the hospital, but we're able to do titrations for both invasive and non-invasive patients. They're done without hospital admission. So this is easier for our families. It's cheaper overall for the hospital and patients in general. They're able to come in just for the night, and we're able to do some titrations on their ventilators. We do both capped and open trach studies. We do frequently downsize trachs in the lab, and that's another reason why the dually credentialed RRT, RPSG team can work for us. They're able to downsize trachs at the bedside. They're also familiar with cuffs, minimal leak technique if we need to use it to get values, and suctioning patients if the caregiver is not available. Having the cardiopulmonary science background and experience in the respiratory field, on some of our sickest kids that come through, they are able to often recognize respiratory distress. We've identified kids literally in the lobby as we're picking them up and brought them right to the ER. They ended up in PICU that night. So having that respiratory background with some of these sickest kids does help having RRTs on staff. And they also, for our dually credentialed RTs and sleep techs, they're able to assist with staff shortages on the inpatient side, work some OT, and maintain their inpatient skills. And I just wanted to go back. So another reason that we do employ both, the state of Florida has very unclear guidelines with the use of trachs and invasive ventilation. So in one place it'll say that if you're trained properly, you can work with these patients, and in other places it says you must be an RT. So because of the large population of trach patients that we see, legal did make the decision that with any invasively ventilated trach patient that we do need to have RRTs on staff. So that can vary from state to state. Our patients in pediatric sleep lab range anywhere from 2 days old to 18, 21 if they have approval from the chief medical officer. We do well patients, no fever or illness. They must be accompanied by an adult unless they're 18, and we do see some 18-year-olds that are able to self-care, but typically not. Our study times start early, and we discharge about 5:30. Where you get into a pediatric lab, we get the extras, and that is extra siblings. We are a family-based facility, so we get extra siblings, extra parents, extra grandparents, sometimes neighbors. Therapy dogs are our favorite. We've had requests for therapy cats, therapy snakes, therapy lizards. If we get a request for a therapy miniature pony, we do have to accept that, and I'm waiting for that day, but by state law, we have to accept miniature ponies. The weirdest one is probably the therapy leeches that came to a sleep study, and that parent or that child had 2 leeches that were brought specifically from Africa for him, and one would undulate to rhythmically put him to sleep, and the other provided pebble pushing across the jar to give him ASMR relaxation noises. So a lot of extras in the pediatric lab that you may not see in the adult lab. Our common diagnoses are listed here. Enlarged tonsils and adenoids are our largest, our most common diagnosis. Some of these do cross over into the adult world, but enlarged tonsils or adenoids are the biggest draw. We see a lot of neuromuscular patients, and that's where the respiratory vents and these complex titrations do come into play. A lot of spinal muscular atrophy. We have these clinics. Any of the patients with hypotonia, respiratory failure, we do consider complex patients, anyone with oxygen, CPAP, BiPAP, or volume ventilation. These are typically with our respiratory therapists, although if they are non-invasively being treated, then they can be with either staff member. Occasionally we do inpatients. We try not to. It's not a great environment for a sleep study, but we have 7 portable units that do roll over into the hospital, and those are typically just if they're DCing patients with new vent or PAP orders. Insurance will not approve without a sleep study. If they're looking at decannulating patients before discharge, and in the NICU we do go in and study our babies with Pierre Robin to see if they need the surgery before they're discharged. Most common referrals in the pediatric lab is our ENT providers and pulmonary. We do see a lot of multidisciplinary specialty clinics that refer, but our pediatricians out in the community are doing a great job these days, and I think cell phones have played a big part in that allows parents to be able to videotape their kids gasping, choking, snoring. So pediatricians are now referring a ton of patients to us, but ENT and pulmonary are definitely the big referrals into our lab. Pediatric versus adult, again, we're just going to look at a few things. Difference-wise, we do require that they always be accompanied by a guardian. They're very uncooperative, often, difficult to set up and maintain, and I did include the picture in the field because we have had a patient escape out the lobby and run across to the cow pasture that we have across from our hospital, and the tech actually went and sat in the cow pasture for about a half an hour and talked the patient back in. It was a teenager with Down syndrome, and 4 techs proceeded to set the patient up, one to hold each hand, one to sing the wheels on the bus about 147 times, and one to set the leads up. So it's a little chaotic those first couple hours in a pediatric lab. There's a lot of crying, sometimes screaming, sometimes it's the techs, most of the times it's the parents. We always monitor CO2 in our sleep lab, and it's just been for the 20 years I've been there. So I do know there are some sleep labs that don't monitor CO2. It is recommended by the ASM, but we always have transcutaneous and tidal or both on our patients. Again, we do invasive and non-invasive ventilation. It's titrated in the lab, and we do save that hospital admission. So that's going to make sense for some of you and some of you not. Being hospital-based and having PICU and NICU right across the hallway is definitely a benefit. But in our lab, this made sense to bring these complex patients into the sleep lab and save the hospital admission for, we are often in red census for these acutely ill patients. Diagnoses and medications are different. Obviously, and again, we talked about tonsils and adenoids. Those are the biggest draw into the pediatric lab. Scoring rule differences that we look at with pediatric and adult. Our event duration is 2 baseline breaths. So in the adult world and with our 18-year-old patients, we do use the 10-second rule for events. Mixed apnea, the order does not matter for our pediatric patients. The central versus obstructive component can be either first or second. For staging our infant patients, we do use infant staging for the 0 to 2 month olds. And then hypoventilation is defined differently by the ASM for pediatric patients, and we're going to start looking at that. So CO2 for our peds patients, greater than 50 for 25% of the night. And that key definition of hypoventilation is where we've taken and developed these protocols. For adults, it's a little more confusing, but CO2 greater than 55 for 10 minutes or more, or an increase of 10 for 10 minutes if it's over 50. So again, with our patients that are 18 and above, we are looking at that definition, but primarily we're looking at greater than 50 for a quarter of the night while they're asleep. When we look at CO2 monitoring, we definitely have pros and cons for each. For our end-tidal, and again, we have both in each room. End-tidal CO2 monitoring, our pros, we have a flow channel. It does add a flow channel. So anytime you can add a flow channel, that's a great thing in a sleep study. It works in most positions. These kids are pretty crazy and gator roll and do all kinds of things in the bed, but for the most part, we tape the nasal cannulas onto their cheeks, and it works in most positions if you can keep it on. We never give false high readings. We may have one slide actually in one of the case studies where the readings seemed a little bit high, but typically, unless the patient is stuck with their face under covers, you're not going to get a false high reading on an end-tidal. And the costs in general are lower for end-tidal machines versus transcutaneous. The cons that we see are flow dropouts with mouth breathing and congestion. Any kids with congestion, allergies, we see those a lot. And we do have the cannulas that have that mouth drop, and still, we'll see in some of the case studies that it becomes very unreliable often. It can be uncomfortable. We have a lot of kids ripping and pulling leads all night, and certainly that cannula that's across their lip gets pulled off. We do give frequent false low readings, and we're going to see that in some of the case studies that we look at. Anytime we add O2 or PAP, anytime you're going to add flow blowing over that cannula, you're going to get a diluted or absent end tidal reading, and we're going to see that in some of the case studies. Again, we have tubing that clogs with secretions, and right now my biggest con for end tidal machines is that we cannot find end tidal CO2 machines that have analog hookups for our sleep software and hardware. So we have a lab full of them with no resource to be able to replace them, and they are at end of life and out of service. So that is a big con for us, obviously, in our sleep lab. When we look at transcutaneous monitoring, again, we do offer that in every single room. This is comfortable for the patients. We typically use the forehead or the clavicle for placement. It does go to the back occasionally if we have front sleepers. There's no false low readings with transcutaneous. If it comes off, we lose the reading, so there's no false low readings. The trend plots are reliable, and for the machine that we use, we have RHP values, relative heating power values, so we can tell if that number has drifted off by 10, that the sensor or the site is compromised, so we can go in and adjust. It can be used with O2, PAP, vent. The transcutaneous monitors are not affected by any kind of therapy, so that's a plus for us. Sites can be changed. Rings are expensive. We try not to change those if we don't have to, but we can apply multiple rings, and as the patient flips and flops around in the bed, we can move that sensor around. And it does also offer heart rate and SAT values to compare to, so we can, if the heart rate and SAT is matching up with what our sleep software is bringing in, then we feel pretty reliable on that transcutaneous value. Cons for transcutaneous monitoring can be the supply costs. It does have occasional high readings. We had a very love-hate relationship with transcutaneous in the beginning. It was supplied by a third-party vendor. We didn't know how to use them. We didn't know how to troubleshoot them. I think both major companies out there that do transcutaneous monitoring now have dedicated territory managers and clinical app specialists that will come to your lab, teach you how to use it, teach you how to troubleshoot it. And so now we have a love-love relationship with transcutaneous. It tends to stay on, patients don't pull it off, and they're very reliable. So I would recommend, if you're struggling, if you do have transcutaneous monitoring and you're struggling, reach out to your territory managers or your app specialists with your company and have them come out and help. Sensors and cables can be costly, and we've had patients just rip them apart. We've had them closed in bed rails, so those are a cost if you do have your sensor cables or your sensors in general damaged. We are a little transcutaneous biased because of the complexity of the patients we see, and we prefer these transcutaneous monitors for, again, any patients that have vent, PAP, and O2, and that would be for dilution purposes and sometimes for cooperation. Patients with nasal congestion, facial deformities that the cannula may not stay on properly, mouth breathers, infants with night feedings. If you are putting, whether it's breast or bottle, to a baby's mouth and you've got a cannula blocking that airway, you've created an airway obstruction. Patients with sensory issues, we do see a lot of children with autism in our lab, so typically on the face, they do not tolerate things on their face very well, so we like to go to the transcutaneous on that, and we'll move down to the clavicle back somewhere where it's not on the face. Anyone with copious secretions, patients who sleep prone, again, that cannula can trap and get uncomfortable there if they're sleeping prone. Restless sleepers, and for inpatient studies, because we do monitor from the sleep lab, we typically don't stay in the room with the patient. It's a lot of running back and forth, so if the child's removing these cannulas and pulling them off, the transcutaneous is typically much more solid, so it saves us some trips back and forth. The ASM manual for scoring and sleep-associated events does define, as we talked about earlier, hypoventilation for pediatrics as a CO2 greater than 50 for greater than 25% of the night. This is the definition that we use to make 4 different policy and protocols that we use in our lab. The first one is hypoventilation in general. So if we have a patient come in and their CO2 values are greater than 50 for 25% of the total sleep time after 4 hours, the tech will initiate BiPAP for our patients. We will go through and make sure the sensor is good. We will change out the machine if it's questionable, if this child didn't look like there was any reason to have high CO2s, there's not a history. But if we have hypoventilation, we will split to BiPAP with a CO2 greater than 50 for at least 25% of the night of sleep time. If we are already titrating a CPAP and we reach maximum pressure, which for us is 15, the CO2 remains greater than 50 for 25% of that time on CPAP, or there are obstructive events beyond while you're on 15 and we're still having obstructive events, we are going to initiate BiPAP. So using CO2, that is part of our protocol to go from CPAP to BiPAP in our lab. For BiPAP titrations, for diagnoses of restrictive lung disease, obesity hypoventilation syndrome, our neuromuscular disorders, and respiratory failure, we initiate volume ventilation after at least 30 minutes of max BiPAP pressures, and that's based on age in our lab. So if our CO2 is greater than 50 for 25% of the time, once we've hit max BiPAP pressures, the tech will initiate volume ventilation based on CO2 values. And it is also SATs less than 90 for greater than 5% and 2 hours due to obstructive events. So there are a few other pieces to our policy and protocols, and I haven't put all of them in here, but we're focusing on those CO2 values. So these are the first three where we incorporate CO2. And the fourth one being with cap-trach studies. If we're looking at a cap-trach study, they're ready for decannulation. If that patient has a CO2 greater than 50 for 25% of its total sleep time after 4 hours, we will consider that a failed capped trach study. Typically open the trach. We have a case study where it did remain closed. And then we'll usually come back in about 6 months, sometimes a year, and try again. So we also look at work of breathing and other symptoms that are going on, but Part A of this policy does state for CO2s greater than 50, we're gonna open that cap on the trach. And we have some case studies to look at here, and again, this is transcutaneous versus end tidal. You're gonna see and so some of these cases, both of them were working great, but basically using CO2 as a tool in the lab and how that comes across. So I think most everybody here has looked at a sleep study. This is just a sample 2-minute screen. This patient came in, we were expecting an 8/4 BiPAP titration, no problem. This kid came in super severe, and we're gonna see the hypnogram and the chart later on this patient, but you're seeing right away complete obstruction here. Tech is trying to get CO2, they're trying to add rate, basically trying to get the airway opened at this point. But you will see down at the bottom, we're running transcutaneous, it's the purple numbers, so that's coming across live in our software along with the SATs. Our first one is a 4-year-old. This patient came in with asthma, snoring, and had an adenoidectomy in 2022. Ultimately diagnosed with mild OSA, and the AHI was 2. Oh, okay, so I have a little bit of a pointer here. So our end tidal, and I tried to label them pretty well for you. Our end tidal and our transcutaneous here are pretty much mimicking each other. They've got the same waveforms, not too bad, although you will see right here is that is 20. So these values with the end tidal are dropping out, but it's overall not too bad if you're looking for a trend compared to transcutaneous. We do see a little spike here, patient woke up, but this one, not too bad, although you will see, again, and it can be with mouth breathing, it can be positional, they sometimes gets pushed up over their nose, different things, but we see some washout with this end tidal, but overall not too bad in comparison. This is a 2.5-year-old, enlarged tonsils and adenoids, snoring and mouth breathing, and ultimately diagnosed with severe OSA for us, which is over 10, AHI of 13. So here, the end tidal was kind of just a wash. And the 2.5-year-old doesn't always tolerate it, oftentimes mouth breathers, especially with the enlarged tonsils. So we're really even less than 15 for a lot of this night. Our transcutaneous monitor picked up in the low 30s and gave us a nice trend all night. It did spike here, and that looked like in the first REM period. So the tech, I think, questioned it, although we did see an increase in end tidal as well. Went ahead and recalibrated right here just to be sure. But then we do see the spike again in REM and also desaturations. So here, transcutaneous provided a nice trend plot for the night, and end tidal was a wash for most of it. This is a 3-year-old witnessed apnea by the parents, enlarged tonsils and adenoids, sleep disordered breathing, and again came in with a severe OSA diagnosis with an AHI of 18. Here we did have both placed on the patient. End tidal, this is your 20 line right here, and for the whole night, it was under 20, a lot of it under 10. Oh, sorry, that was 30, 20, 10, a good part of it 10 and under. And our transcutaneous did really well over the night. Looks like the patient woke up here quite a few times, probably pulled the sensor off, or may have had to go to the bathroom in here. But we have a nice trend plot here, dipped down a little bit right before the REM period and the patient woke up. But again, so we're falling out with end tidal, and transcutaneous, which is what we find often in the lab, does provide a more solid, reliable trend. This patient was a 2-year-old, tracheomalacia and oropharyngeal dysphagia. Came up with moderate OSA with an AHI of 7.7, did have DSATs below 70, and CO2 retention when capped. So this was a cap trach study. This patient would not tolerate the cannula being placed at all. We were not able to get a cannula. So I did put the red line at 50, and we can see here, once this child went to sleep, CO2 climbed over 50 and pretty much stayed there for the majority of the night. So this was considered a failed cap trach study. Patient went home, came back 6 months later, did great, had grown a little bit, airway got a little bit bigger, and was able to go and get decannulated. But this was a failed cap trach study. Without a transcutaneous monitor in this case, we would not have had CO2. So with an AHI of 7.7, they may have held the decannulation and probably would have. Typically for us, 5 is what we look at treating, an AHI greater than 5. But the CO2 definitely did push this into a failed status. This one is a 5-year-old, sleep apnea, snoring, and the parents did not believe that this child needed PAP therapy. They refused to put the kid on PAP, so the pulmonologist wanted us to do a diagnostic study to prove to the parents. Severe OSA, AHI was 47, and low SAT was 51. We did have, we did have end tidal on here, and it wasn't doing too bad of a job. The tech did add oxygen at this point for the desaturations, and at that point we lost end tidal. So with the transcutaneous in place, we see that it did climb a bit. It peaked during REM periods, and all our almost blue line of hypopnea is there. So the pulmonologist, sleep medicine doctor, was able to prove to the parents, that this child stops breathing or struggles to breathe 47 times a night. This one is 15-month-old, Down syndrome, hypoxia, snoring, and hypotonia history. Severe AHI of 22 with hypoxemia. On this patient, again, we did have end tidal in place. Once we placed oxygen on the patient, though, we lost our reading. I can tell you the tech earned their paycheck this night with how many times this sensor came off. Looks like it was added right in here, off, all these drops down to 0. The sensor was off, put back on, potentially recalibrated. They were in the room at least, looks like 20 times here to try to keep CO2 so that we could see how this patient was doing. And again, they did add the O2, which took our end tidal out of play. So we use both, and we always hope to keep both on, but once we add some therapy, usually we lose that end tidal. 6-year-old OSA, enlarged tonsils and adenoids, history of snoring and allergic rhinitis. This AHI was 12, so it's considered severe for us. And this patient was split to CPAP. This was a 6-year-old split, and I did put this line in here where you can see. And here's a case where, again, with some washout on the end tidal when we're looking at it, we had it in place. They were mimicking each other pretty well, a little bit of dropout here and there. But once we added some flow, and a lot of times our techs, depending on the mask they're using, this would have been one that went over it. They'll leave that cannula in place because of the tape that's on the cheek, put the mask over it. If we're using a wisp or something really small, they do have to remove it, but in this case, they were able to keep the mask on, and you'll see the washout. So the end tidal's actually dropping here, where with the transcutaneous, we're seeing it actually peaking, and it's correlating with these obstructive events. So we're seeing the rise, where with the end tidal and the C flow that's going over it, we're seeing the washout. This is one of our older patients, 19 years old. This is the patient that we saw the 2-minute screen of in the beginning. Post tonsils and adenoids. This patient does have a history of PVCs, Down syndrome, CP, and has a previous diagnosis of OSA and is on BiPAP. Again, diagnosed with severe OSA. So we came in, patient coming in was on 8/4, and right away went into all these events, DSATs, CO2 climbed immediately up over 50. Looks like hit as high as almost 60 there. So the tech had to start titrating right away. Was able to get to high values, actually added some rate, and I think that right where he added rate here is where we saw that tech note where he added a rate of 8. And actually this kid might have come in on 12/5, it looks like, to start. 10/5. Added the rate, titrated up, and then sat for the most part with very few events. And we do always go back to home settings at the end. But again, a case where this transcutaneous monitor was helpful. Once we got him titrated up, pretty much dropped down. We had one little REM period here where it spiked a little bit, but our TCO2 monitor is showing us that we are ventilating well, along with the drop in events. And this is the table for that titration. So you can see our CO2s, our max CO2s through the night until we got to those high settings, which for this patient were 20/16, rate of 12. Didn't drop down into the 40s until then. The tech did also add oxygen. The PVCs that we were seeing frequently in the beginning of the study, once we got them fully titrated pressure-wise, they were very infrequent, and then oxygen was added here, and then it went down to, I think we just had a few by the end of the study. So this was a successful titration, but unexpected. We did not expect it to be this severe coming in. This is a 9-year-old, history of snoring, sleep disordered breathing, and enlarged tonsils. Severe OSA, and this patient was actually split to CPAP. Oh, lost my P on CPAP there. And then BiPAP once we hit max pressures. So our end tidal, trend-wise, not doing too bad actually. It does kind of fall out once we switch over here near the BiPAP. It falls out a little bit more, but these readings up and down, 20 to 30, all over the place. We get a better trend plot. For obvious reasons, we're not blowing flow over the transcutaneous sensor like we are on this end tidal. So CPAP to start, titrated up to max pressures, split to BiPAP, and trend-wise, this would have been okay. We do see that same trend with the drop. with the transcutaneous a little bit more reliable here. This is a 15-year-old OSA patient, spinal fusion, chromosome abnormality, and a history of chronic respiratory failure. So this is one where the patient came in. We did know that he was on BiPAP, so he started on BiPAP 8/4, was titrated up, hit max settings. Our CO2 from the beginning hit 50 and just climbed. We got as high as, looks like 77. Here we recalibrated the machine, and at this point a new machine was brought in just to make sure. We don't want to change modalities or put patients on typically if we're unsure, and with these high numbers in the 60s and 70s, we definitely question that, so it was recalibrated here and a new machine was placed completely here. So once we switched over to volume ventilation, we see that this does tend to trend down. Never got it under 50. This patient is probably a CO2 retainer. We did not have information on that to look at past studies, but we do have a table here, and you can see our most ideal setting was the very last one on volume ventilation, and our low CO2 was 56 for the night there, so that was our win. And then at the very end, put back. Now in this case, they did call the pulmonologist on call. They did not go back to home settings of 8/4. They actually sent them home on 20/12 and a rate of 15 so that they could get a volume ventilator for this patient. This is a trach patient, 19-month-old, history of BPD, nocturnal respiratory insufficiency, pulmonary hypertension, and developmental delay. So this one we did, again, have both end tidal and transcutaneous. Patient woke up here, looks like may have went to the bathroom, not sure what was going on. Transcutaneous was off for a while. End tidal CO2, trend-wise, not doing too bad. Numbers are similar, just a lot of in and out. You are dropping down to 10, 20s, so not reliable. On your study, you're gonna see those CO2s of 10, 15, 16, 8, whatever's going on. But when you look at the overall trend, it's not too bad. Here with the transcutaneous, we're seeing that nice steady until it came off here and finished for the night. Oh, I forgot one thing. So this was actually a ventilator titration, and we were able to down titrate. So both of these do show our CO2s under 50, and typically we're keeping our vent patients 35 to 45 on their CO2. Sometimes the providers just order CO2 under 50. So the tech did actually down titrate this ventilator a little bit based on these CO2s, and both monitors in this case would have provided appropriate readings to go ahead and down titrate this vent. So finally, in summary, we looked at some key differences between the pediatric and adult world and their needs, their common diagnoses, the scoring rule differences. I'm not sure how many of you actually do peds in your labs or work with the pediatric population, but the definition of hypoventilation for peds is what we really use to develop the policies and protocols to be able to enable our technologists and our RTs to either initiate therapy and titrate that therapy accordingly. Your lab may or may not benefit from having respiratory therapists on staff. Ours does. It does allow us to do these ventilator titrations and treat these most complex respiratory patients, and I know that's what the adult world is also seeing in sleep labs. Our regular patients are having home sleep studies, which doesn't happen in pediatric labs. So staffing our RTs may or may not make sense to your lab, but in this particular case it did for ours. And it's not a full staff of RTs, but they do take a lot of those the most complex ventilator, the complex titrations. End tidal and transcutaneous CO2s both have their pros and cons in the sleep lab, and we looked at those. And we looked at quite a few case studies where we effectively use these CO2s, both end tidal and transcutaneous, to help us assess, identify, and treat our severe patients. And our providers are comfortable and and appreciate the fact that some of these patients are only here once and not having to come back for that second study with a wait that's taking out till September and October. I want to thank you for staying for my talk, and if you have any questions, you can reach out to me by email or, yep.
Any questions for Lisa? None?
Right here.
Oh, didn't see you there. Well, we need to have you on so the people at home can hear you. I want to remind the viewers on Zoom to, if you have questions for the lectures, please put them in the Q&A section, not in chat.
Just a question. What's the tech-to-patient ratio when you have difficult patients? Is it 2 to 1 or 1 to 1?
So we live in the 2-to-1 space. Pediatrics is what we do. So we do try to put a complex and a simple patient. We have an acuity system that we go by. We have an odd number of rooms in our lab. We have 9 rooms. So if we have a full house booked, there is one tech that has a 3-patient assignment. They pick the easiest patients. They get first pick of everything. Oftentimes we will have at least one patient fall off. It falls back to our normal ratios. We have, in the 20 years, probably made a purposeful one-to-one assignment about 16 or 18 times, and that's it. A ventilator patient can really just lay there and not be combative in any way. You can have a 7-year-old that rips everything off all night. So on paper, sometimes it looks great, but we typically do 2 to 1. If we have no shows, it falls to 1 to 1 often, so that whoever has the ventilator or the complex kid will definitely stay in the 1 to 1 spot.
Russ Rosinski.
Yeah, just had a question. When you switch them over to bi-level, you never adjusted IPAP and EPAP spread more than 4. Is there a reason?
No, we do. We do. Those cases, I think, yeah, just had it, but yep. As far as, you can go as far as 10, 4 to 10.
Got a question over there? Wait till I get to you.
Do you find a benefit for the end title? Do you use oral nasal or just nasal? Does one get better connection or reading than the other?
So we have both stocked in our lab. While the techs are setting up the patients, they're looking to see if they're already mouth breathers while they're awake, they're probably going to put that nasal oral drop on there. The infant ones don't have the oral drop. They're tiny, and we cut the prongs off on most kids to make them more comfortable, and they're still ripping and pulling on them. But we do offer both, so it's kind of the tech can decide, or they can start with one without the mouth drop if they notice during the night they're doing more mouth breathing. They can certainly change them out, but they have both available.
All right, we have one question on Zoom. Do you use full face masks for kids? What age?
So we do use full face masks for some kids, and we have the like the literal, what are they called? I can't think of the name. We call them the fireman masks, but actually that encompass the whole face and the nasal oral, depending on the age. And sometimes even the older kids, though, if they are choke hazards or they're unable to clear their airway, we obviously cannot do that. So if they're nose and mouth breathers, and typically 5, 6, 7 years old is where we're going to switch over to that. Most of our little kids are using the little wisps, things like that, the smaller masks, nasal oral, or the nasal masks, not the oral.
All right. Since we're bumping up against our time. Was there a follow-up question there? Okay. We're bumping up against our time. Todd Burchard says, great talk, Lisa. Good seeing you.
Thank you.
On chat. And thanks, Lisa. Great job.